as it's spelled.
Great stuff. Okay, so I'm joined today by Simon Mellor, and Simon, thank you very much for joining us. Simon's a hip and knee surgeon working for Total Orthopaedics, and we can ask I've asked Simon some really interesting questions. Simon does some particularly
in terms of always replace it.
I don't know if we say we're too individual or not, but where do you sit hip surgery, which I really want to ask Simon about. But before we do that, we're just going to ask a few questions on knees.
Always try
again the joint.
If you're talking about one thing that I've been asking some different consultants is different approaches and different ideas regarding
surgery.
Knee replacement.
The joint replacement, the joint registry data is useful for
first
us.
Question I've got for you is,
there are
in your practice and in your opinion, where do you sit with kind of robotics versus non-robotics?
Reports on outcome data for different designs of knee replacements with or without replacing the underside. It's a fascinating topic to look at. So for the benefit of important to know your viewers, if you have a knee replacement surgery has evolved and progressed over the last 30 years, there doesn't seem to be much swiftly in terms of benefit available to replacing the underside of the kneecap. Progress in knee replacement, if you have an implant which doesn't have a particularly patella-friendly groove, joint registry data, groove that the groove that the kneecap sits in, people have knee replacements. Then if you don't replace that patient's kneecap, then anterior knee pain after knee replacement surgery is going to be more of an issue. And there are different stories, different rules for different designs. Most of the more modern designs are actually quite different figures are there are occasions when you feel that you do have to ballpark figures say that something like 5 to 10% of patients, if the kneecap even a year, 18 months, 2 years after a knee replacement onto the front of your knee replacement design, once you've finished and the majority of the operation, some of those people are not for some reason that kneecap doesn't sit nicely within the groove that is there on the surface of the metal implant, stiffness, then occasionally you have to start hardcore percentage addressing that so that the patient will be satisfied with it. Goes fine, whether that means releasing soft tissues to improve the position, the knee moves fine, kneecap in the groove, or sometimes actually to decide to resurface the kneecap specifically to thin the kneecap out. If you have a very bulky kneecap and the size of the kneecap means that it wants to tilt off the 100% surface of the thigh bone implant with their knee replacement. Now, no amount of release will necessarily improve that. But once you've resurfaced the kneecap and chosen to resect more of the kneecap than maybe you normally do when you do a resurfacing, you can actually improve the position of the kneecap on the surface of the thigh bone. So by and large, that's a rare situation, to be honest. Hip is a ball and socket joint. The biomechanics. If a patient specifically complains of significant anterior knee pain, the knee is much more as a major component of their arthritis within the knee, although you might think of it just as a hinge joint. And when you open up the knee joint, there really is very bad ridging and grooving. There you have called eburnated bone on the surface of the kneecap. You have the kneecap to deal with. Some people will look at that and say, well, this patient is not going to be satisfied without a resurfacing of the kneecap. So that's a judgment call that the surgeon may well take at the time of surgery. Even a good knee replacement. There are some surgeons who will look at the published literature and say very clearly, a lot of people will say, replacements work very well. I can feel it when you always resurface the patella. And there are some surgeons who will pull up another series of papers which say knee replacements always work very well as long as you don't resurface the patella. So there is not a black and white to try and work out. Famously, there was a well-known to make that patient orthopedic surgeon who used to go to and Robotic the UK National Conference for orthopedic surgeons every year. They would often have a debate pretty much every other year about whether or not, this is back in decades ago, and there would be a debate, should you resurface the patella knee replacement surgery, flexibility of the knee? And famously on one occasion he stood up and he said, I've done a lot of knee replacements over my career of the knee replacement, and one thing I can tell you is very clear, you should always resurface the patella. And then he turned up at the meeting a few years later when they had the same debate. There was a fad, and he stood up and he said, having studied this very, very extensively, I can tell you, technology then never really up to scratch. So if one surgeon with a great experience in knee replacement surgery can't make up his mind, and so quite often you'd start doing an operation using a robot to assist you. Personally, my own practice, I've seen software would crash. The number of patients waiting and under my realise that you weren't getting anywhere. End up saying, well, that's not really working. But that's partly to do with the fact that we changed the routine knee replacement implant that I use in the NHS from an implant which maybe isn't as patella friendly, and therefore I felt that I had to do resurfacing of the kneecap frequently. We now use an implant which is much more modern, much more in design. It's more patella friendly.
If only it were that way.
I don't feel the need to resurface.
And that's obviously not the case. So can you explain to people what the robot actually does or doesn't do?
Yeah. So the idea of a robot in knee replacement surgery is to try and improve the accuracy of where we cut the bone. You have to cut out bits of bone so that you can fit in the new artificial knee joint.
Yeah.
And the traditional way of doing that is during the operation using what we call alignment devices. So metal rods inserted into the bone and jigs that are attached to those rods temporarily to identify where the cuts are made. But those are reliant on how well the rod fits in the bone, and there's always a bit of give and play with those devices. The idea of a robot is it's a bit like that sort of what you said in the car factory. It's a mechanical arm that's attached to a large robotic device, the computer as it were, and this robotic arm comes into the field of surgery. The surgeon holds the robotic arm, and the idea of this system is that the robot, in advance of starting the cutting of the bone, the robot recognizes and registers the shape of the bone that you're about to cut and calculates where you should remove bone and where you shouldn't remove bone. And the robotic arm will have maybe a sawing device attached to it, or quite often a burring device, so a high-speed burr. And the surgeon grabs hold of this robotic arm, and the robotic arm will only move in certain areas. If the surgeon keeps to the area where the bone has to be removed, the robot lets you do it. But the robot stops you from swinging the arm out of that region of cutting. So that's the theory. So it's reliant on the robot being able to register details of the bone, whether that's a scan that's been uploaded prior to surgery, or whether it's actually, quite commonly, the robot's system. You start the operation by taking some time to register surface landmarks of the bone. The robot recognizes those surface landmarks and then equates that to what the scan before the surgery showed up, and therefore calculates what bone needs to be removed and what bone needs to be preserved.
So in theory, it's trying to take the chance of human error out.
Exactly. Now, the problems with robotic surgery are that it's very expensive equipment. You might spend £1 million buying a robot, and especially in the NHS, you have to be able to justify that sort of expenditure to decide whether it's actually going to make a significant difference to outcomes. And that's what's difficult. Trying to measure these outcome variables can be very difficult. So there are alternatives. Personally, I don't use robotic surgery. I've used navigation for knee replacements before, and that's something like what I described before. There's a robot in the operating theatre, and you spend some time recording data points on the bone, and then the robot guides you. It won't actually stop you from making a wrong cut like the robot does, but the computer shows you where the accurate alignment is. And that's a well tried and tested system that works well. It adds surgical time. If you're trying to get a good outcome from a knee replacement, you could spend hours trying to finesse your preparations to the perfect level, but that may not actually result in a better outcome for the patient, because the longer the surgery goes on, there are other side effects of that: bleeding, risk of infection. So again, it's a balancing act. My own personal practice, I've moved towards the use of something called patient-specific instruments, or PSI. And what that means is, we're again trying to improve accuracy or alignment of the implant. The way I do that is the patient has a scan before the surgery, and we do the navigation before surgery, basically. So we're not wasting time in theatres. The CT scan of the patient's knee is then turned into 3D printed cutting jigs specific for the patient, so that when you come to do the operation, rather than relying on maybe accurate, maybe not accurate jigs that are off, standard equipment, instead in the operating theatre, we have a sterile jig that has been manufactured before surgery for that patient and that patient only. It fits onto the bone perfectly. It has a slot in it to show you where you cut the bone. And that, I find, works very well. It gives me good accuracy for the preparation of the bone, and it doesn't delay me in surgery. It allows me to proceed through the operation very swiftly. And I've been using most recently, there's a company called Conformis, which is becoming quite well known for doing this sort of technology, combined, if necessary, with custom-made knee replacements. So then we're looking at changing the implant itself, and specifically looking at the issues with off-the-shelf implants versus an implant that is specifically the right size and shape for your particular patient. In the operating theatre, if I'm doing a, in inverted commas, standard knee replacement, I will open up the knee and then do measurements and calculate the size of the implant that's needed. But in the operating theatre, I have a range of sizes available to me. For example, size 1, 2, 3, 4, 5, 6.
Yep.
But my patient might be a size 4.35 rather than being a size 4 or a size 5. And then obviously you are worrying about trying to make the patient fit the implant rather than the implant fit the patient.
Yeah,
you've probably heard this before.
Yeah, I have. And again, correct me if I'm wrong in my understanding here, but how I've come to understand it is, like you say, if you have a patient who, let's say, is a perfect size 4 and you have a size 4 prosthesis, then great, there's a good match. But as you say, if they're a 4.3 and you've only got either the 4 or the 5, there's going to be a mismatch between that prosthesis and the bone that it's sitting on, and there can sometimes be like a little overshelf or
overhang or underhang, or undersizing.
And the theory is that can sometimes be a source of soft tissue irritation after the knee replacement. Maybe that's why it doesn't feel quite right. Maybe it's why it's prolonged bit of inflammation. It doesn't. They're not maybe making the recovery that they were expecting, perhaps because of that slight mismatch. Is that
exactly right? And so, if it's feasible to get an implant that is exactly the right size and shape for a patient, logic to me would suggest that that's going to be better for the patient. Yeah. And in fact, this Conformis knee replacement, it's been around now long enough that we can see the early outcomes on our national joint registry data. We collect the data for all knee replacements and hip replacements in the country, and we've used that for decades as a way to judge what works and what doesn't work. And it's a fairly crude measurement because it looks at failure. Does the patient need to have revision or redo surgery? And the Conformis implants that have been put in over the last few years are performing really well, better than the rest of the knee replacements at an equivalent stage after surgery. So there's a justification there.
Yeah. And would you say, in terms of just anecdotally, the patient, because a lot of the surgeons that I speak to who do the Conformis, or have, let's say, have progressed to the Conformis, they often say to me anecdotally, they say, off the record, I have noticed my patient, a bit more like the hips you're saying, I noticed the patients are happier generally.
I've seen a difference, I have to say. It's difficult to quantify and to prove. It comes back to this discussion we had before about that 5 to 10% of dissatisfied patients. Time will tell, but for me, the early indicators are that maybe using something like custom knee replacement with patient-specific alignment of that implant, using 3D printed jigs, is a fairly low-tech, believe it or not, simple, not very expensive way of trying to improve outcomes. And that's why I've focused on that rather than at this stage investigating the option of robotic surgery. That's not to say I wouldn't be interested in looking for that method perhaps in the future.
But at the moment, is again when I've been researching, it's one of the other aspects I've found that people advocate for robotic, the true sort of robotic stuff is they're saying you're removing less bone and therefore kind of revision of surgery is easier. But again, I understand that with the Conformis in particular, you mentioned, and the patient said that again, that's also you're removing less bone, made and all of those things. So kind of it's almost it's matching out that argument, it seems.
So any time that you do joint replacement surgery, the sensible surgeon is always thinking about the next potential step. If someone has a knee replacement or a hip replacement, if they're below the age of 60, for example, you need to be thinking, well, maybe even with my best attempts, this patient's knee replacement may not outlive them. It may wear out, fail, or loosen at some stage in their life. And subsequent surgery, one of the biggest difficulties of dealing with redo or revision surgery is dealing with the amount of bone loss. Once you've lost bone, you can't regain it very easily. So it makes your challenges much more significant if you have to do redo surgery. So yes, preserving bone is a major issue. That's the same reason why I'm an advocate of partial knee replacement surgery in patients where it is indicated, because you're preserving as much of the joint as possible. Yes, the patient is in pain and needs joint replacement surgery, but if their arthritis is only localized to one small area and you can just replace that small area, not the whole knee joint, well, you've retained as much of their joint and their soft tissues and their ligaments, which for the future is going to be a beneficial thing.
Yeah. Is there sometimes a difficult line to draw though, in terms of, if, let's say, for example, somebody who's got, lateral compartment disease, but you can see the medial compartment is not great, it's not symptomatic maybe yet, but there's some signs of wear and tear. Is there sometimes a difficult decision to be made of, do you stick with the partial, or do you think, do you know what, they're going to be back in a few years' time wanting that medial side done, so then you have to go?
It is a difficult decision sometimes. That's why it's so important to engage with the patient as well. If there's one thing that I'd like to believe that people feel that they get from me as a surgeon when they come to see me, is that I want to engage with my patient. It's a two-way communication to outline the pros and cons of the different treatment options, and then we come to a decision. I'll say to a patient, look, if you're interested in having a well-tried and tested operation for your arthritic knee, and you don't want to think that you're going to need to have redo surgery in 10 years time, then even though you might be suitable for a partial knee replacement now, maybe you want to think about a full knee replacement, which is maybe that little bit more reliable in the long term. But equally, if you are on the younger side, you have isolated arthritis in one area of the knee, and you have an expectation to return to a sporty, active lifestyle, I think that the well-performing partial knee replacement is a better option than the well-performing total knee replacement. In that slightly younger, slightly more sporty individual, they are probably going to prefer that option, but it's a two-way communication.
Absolutely. Taking that as an example, and let's say somebody does have, let's say it's a partial or even a full, but just how active can they be once they've had that done?
The sky is the limit. I never limit my patients. I will say to them, a lot of people come to me and they say, well, doc, after the operation, can I ski? Can I go windsurfing? Can I cycle, etc., tennis, football? And I always say to my patients, it's not my job to limit you in what you do. I can advise you. I can tell you what the implications will be if you go down that route, but it's your joint, it's your knee, it's your hip. So I won't stop you from horse riding or paragliding or whatever it is you want to do.
Yeah.
But you have to decide that with the information in hand. What are the implications to you if you go down that route? The younger you are, the more sporty and active you are, the quicker you will wear out any joint replacement operation, because no joint replacement that we've designed thus far has a guaranteed life expectancy as long as your life expectancy. If you're a 20-year-old and your hope is to carry on playing competitive sport and you need to have a joint replacement, you'd be very unusual. It's very rare that comes up, but clearly you've got maybe 60 years ahead of you. I think nobody can expect a joint replacement to last that long. So then you have to consider, am I going to limit the amount of sports I do after my joint replacement surgery so that I eke out as much of a lifespan from that knee replacement? Or am I going to go for it hell for leather because that's my quality of life now? Well, that's not for me to decide. That's for the patient to decide based on my advice.
Can you put that into any sort of context, though, Simon, in terms of, is it a case of, say somebody, they obviously they understand what you just said, and you say, well, look, more active rather than we're going to wear it out, fair enough. But is it a case of, like, if somebody went back to impact sports, running, football, whatever, is it a case they're going to wear the knee out twice as quick, a bit more, can we? Is there any data or any kind of even anecdotal ideas on? Or is it very hard?
I think there are so many factors here. How heavy is the person? Therefore, how much force they're putting through the implant. Comes back to what we discussed in terms of accuracy of the surgery. An implant that has been put in perfectly compared to one that's just a little bit out of kilter, that one may well wear out more quickly.
Right.
The operation of knee replacement surgery is not just an operation with an implant. The soft tissues, how you manage those soft tissues, what we call balancing of the knee replacement. So the ability to end up with a knee that feels and moves in the right way. That's quite a skillful technique that, the robot doesn't do that for you necessarily. That's where the surgeon is still, an important person in theatre. And so if you have to do releasing of ligaments or balancing of ligaments during the surgery, how well that happens, well, maybe that will have a bearing on how well the knee replacement lasts as well. Because in a knee replacement where the two surfaces are just a little bit out of alignment and there is give, then you're going to get more forces through the polyethylene and therefore maybe earlier debris formation, early deterioration.
So, and then in that example of a youngest patient who's then trying to return to activity, which, and then they get to the point where they do need that revision of surgery, which is it that's the issue? Is it the, or is it even both? Is it the polyethylene wearing out, as you say, the plastic component wearing out, or is it then the aseptic loosening of the bone and the bone loss and the prosthesis losing its place in the bone, or is it
they're linked? They're linked. So polyethylene wear creates debris, which is quite active inside the knee, and the side effect of that debris formation is the aseptic loosening that you mentioned, and the bone osteolysis, which means the slowly erosion of the bone behind the metalwork. It's a direct response to the polyethylene debris, so they're linked. The more polyethylene volume that you produce as wear debris inside the knee, the more this aggressive reaction in the bone takes place, the quicker the loosening takes place.
Right. And does it have any bearing then in terms of if that's happening, that's part of the process? Is there any way the patient can help mitigate that? Obviously by doing less wear, but in terms of, I'm thinking of like bone strengthening activities or bone, is it, how important a factor is it for them to think about their bone health in that equation?
We're all great advocates of maintaining bone health, irrespective of how implants survive. Far more worrying for us is the explosion in osteoporotic fragility fractures throughout the whole body. So yeah, maintaining good bone health is an integral part. Will it stop osteolysis? No. But if you have a better bone quality, if you have more in the way of good quality bone at the starting point, and you try and maintain that bone quality through your life, then you're going to end up with better options were your knee replacement to show signs of failure.
And that obviously for people viewing that comes down to combination nutrition, exercise, strength exercises, but again balancing those strength exercises between impact versus isometric loading, concentric loading, and kind of doing stuff that's joint friendly at the same time.
Absolutely. Joint friendly, weight bearing exercises in the appropriate way, the correct amount of sunlight, the vitamin D, the calcium. My dietitian colleagues tell me that dairy products and milk are not the way to get calcium. The lay person thinks that cheese and milk is the way to get the best amount of calcium. Apparently that's not the case, but I'm not an expert in that field, but that was quite interesting news to me, because I think there's a...
What's the case? What would be the better option? Did I mention?
I think that the correct balanced diet is something that is very contentious at the moment. As I say, I'm not somebody to give that viewpoint. You'll get quite vociferous people who are fanatical about whether it's a dairy diet or a carnivorous diet or a vegan diet. I don't think it's for me to launch into that sort of argument. There are pros and cons, I suspect.
No, the comments on the things otherwise.
I'm sure there'll be lots of
We won't go. Just then,
I think having a healthy diet, trying to maintain a diet that covers all of the bases. Unless you're a strong advocate of one of those particular diets. If you believe that being vegan is the way to maintain your health and bone health, and then that's fine. But for the average person in the street who doesn't really want to know too much about different diets, I think just maintaining a nice spread of dietary constituents is probably the way to go.
So kind of before we get into hips, then my kind of final question really with regards to, again, just wrapping up this sort of bone aseptic loosening thing, and where does the argument for a cemented versus uncemented knee prosthesis come into that? Again, what's the bearing, what's the kind of concept behind, is one preferable to another in terms of that bone health loosening, that bone cement interface or bone prosthesis interface? Again, I've heard sort of arguments both sides of the coin on this one.
Absolutely, and that's because nobody's really sure. When I was training, there had been a bit of a drive for using uncemented knee replacements, total knee replacements, and at that stage, in the 90s, coming towards the millennium, it seemed like a lot of those uncemented knee replacements were actually failing in a way that we don't see with uncemented hip replacements, for example. And so there was a very major swing away from uncemented implants for knees. Everything was put in cemented, which was, my training was with cemented implants. I think there is a potential role for uncemented implants. I think, the thigh bone, the end of the thigh bone, seems to be something that would accept an uncemented femoral component quite easily, because when you're doing a knee replacement, you contour the end of the thigh bone, and then it's a metal cap which fits over the end of the thigh bone. So if you cut the bone just slightly bigger than the metal work that you're putting on, you'll get a good jam fit. So initial stability is not a problem. And then obviously we have very bone-friendly coatings that we can put inside the metalwork where the bone is, so that over time the bone grows into the metalwork and secures it into place long term. The shin bone, the top of the shin bone, the tibial component, was always the more difficult one, because it's not a contained contact area. You can try and create a hole in the bone and then jam in an implant into that surface, but you never know whether it's going to rock or tilt a bit. And so that was always the side that was more difficult. I think they've improved things. And I mean, for example, with the partial knee replacements, one of the biggest selling partial knee replacements in the UK is called the Oxford partial knee replacement. And they have both a cemented and an uncemented version that's now available. And the data says that the uncemented version performs equally as well as the cemented version. With total knee replacements, I'm still not sure. I think the jury is still out to a certain extent. I wouldn't necessarily be advocating uncemented total knee replacements at this stage, but I'm open to be impressed by improving data as it comes available.
Evolving areas, the sound of it. And in terms of, again, perhaps one last question, in terms of evolving things and where things might go in the future, where do you see things going? Or I know there's even different surfaces that are available now. Traditionally, it's like you said, it's a metal prosthesis, but again, what's your experience or thoughts in terms of either now and where things might go in the future with regards to different materials on the bearing surface of the knee?
Yeah, well, I think, yes, you're quite right. That the National Joint Registry that I've mentioned before gives us quite a powerful tool in terms of advising what works and what doesn't work. And for knee replacements, a cobalt chrome alloy metallic implant on the end of the thigh bone, which rests on a cross-linked polyethylene plastic piece on the top of the shin bone, seems to work very well for the vast majority of people in the long run. For the younger patient where you're trying to improve longevity, you want to reduce debris formation. We've talked about the polyethylene being quite an aggressive active debris when it is produced. There are ceramic options that are available. I think they're a bit of a niche at the moment. People are still worried about the fracture rate for ceramics. So for ceramic as a bearing surface is a wonderful thing. We use it routinely in hip replacements. It's a very slippery surface. When you've polished it, it has what we call a good wettability. So it lubricates very well. And we see generally less polyethylene formation, debris formation with ceramic against polyethylene compared to cobalt chrome against polyethylene. But the technology for creating these ceramic implants and getting longevity from them is still a bit contentious. I know what you're going to ask next. Is there a role for pyrocarbon? Pyrocarbon is a wonderful surface with very good friction characteristics. In non-load bearing locations, then it seems to work very well. We've certainly been using it in, not myself, but my colleagues that do hand surgery. It's got a long track record for doing little mini joint replacements in the fingers and the knuckles, which seem to work really well with good long-term data. As we've discussed before, there is a trend towards trialing this at the level of the shoulder joint. When you're in a load-bearing position, the ankle, the hips, the knees, not sure whether pyrocarbon is the future or not. It's very early days to say. I think we need to wait for more data. At the moment, if our national joint registry tells me that a cobalt chrome implant works very well with a polyethylene load-bearing surface, then I'm happy. There are things that we've been tried, changing the cross-linking in the polyethylene. One of the companies routinely provides a polyethylene that's been enriched with vitamin E, which is designed to improve its longevity. We need data from thousands of these to know whether it works or not.
Yeah, the data's not quite there. I know on the shoulders, for example, I think the early, the early versions were showing were showing a high fracture rate, and then the slightly more evolved ones have been less so. But the early ones did certainly fracture. So I think, like you say, it's a different joint, it's a different part of the body. So it's who knows what the future holds. But it's interesting, isn't it? These
absolutely
where these things might go. So that's really good. Let's move on to hips now, because hips obviously is another big aspect of your work, and I know in particular that you offer some hips or hip replacement surgery that is quite unique to some extent, and maybe a lot of surgeons that don't offer this particular anterior approach that you offer. Would you like to just outline that for us?
Yeah, sure. So hip replacement surgery, the hip is a ball and socket joint. We talked about this before. The actual biomechanics are relatively straightforward. The traditional way to put a hip replacement into the hip joint involves a scar on the side of the thigh running into the buttock area, and through that scar the surgeon can enter into the hip joint either skirting over the front of the upper thigh bone or to the back of the upper thigh bone, and that technique works very well. Okay, this is a technique that I was trained to do with this sort of surgery. And I have to admit, up until 9 years ago, I was very happy to be doing standard hip replacement surgery with a standard, what we call the approach, the surgical dissection. My preference was to use something called the posterior approach. And I was very pleased to see how my patients responded to that sort of surgery. And by what I mean is I would do a hip replacement on a patient. The next day they would be sitting out of bed. The day after that, they would be walking with a Zimmer frame or crutches, pain control with appropriate painkillers. By day 3, moving on to sticks or crutches and ready to be discharged from hospital. And then I was offered the opportunity to go to the continent, to Belgium, to see a surgeon doing hip replacement surgery through a different technique. And I have to be honest, I was a bit skeptical. I'd been a consultant for several years. I felt as if I knew what worked and what worked for me. And like a lot of surgeons, I felt that if I was going to consider changing what I did, it would have to be something fairly significant in terms of difference to my patient that would justify me wanting to change. Yeah. So I went to Belgium to see the surgeon operate, and he was using this anterior approach, a cut at the front of the groin. And the real benefit from this technique is, rather than cutting through the skin and then splitting open the buttock muscle, the gluteus maximus muscle, and then detaching muscles or tendons from the side of the thigh bone in order to get into the joint, this technique, after you cut through the skin, there is no muscle damage. Instead, we just sweep or move muscle tissue out of the way, it allows us to get down to the hip joint without damaging muscles and tendons. The actual operation itself is the same surgery, putting a new artificial socket, inserting a new artificial ball attached to a metal rod that goes down the inside of the thigh bone. At the end of the operation, once this new ball and socket is in place, these muscles just flop back into position without any sign of damage. And the stitching up is literally just, a few stitches in the fascial layers and then some stitches to the skin. So that was quite a surprise to me to see this sort of surgery. Technically, it looked a bit more challenging. And actually, during the surgery, I was thinking, well, am I going to want to change what I do to learn this technique? At the end of the day, we went up to the ward to see the first patient. And for me, what I was expecting was a patient lying in bed with a drip, with an oxygen mask on, maybe in a bit of discomfort, but, not in agony. But, this was the typical scenario at the end of that day, having had a surgery at 8 in the morning. Yeah. The patient was walking down the corridor. Right. The patient was walking down the corridor with just one stick for balance, not even really using the stick very much. And at that was my, jaw-dropping moment. At this point, I thought, well, I need to maybe look into this a little bit more closely and decide why this is different to what I see.
Yeah.
And that's how my journey started. And to the point where now my routine practice, unless it's not feasible, is to use anterior approach hip replacement. And it comes down to basic principles. What would I want to offer my patient from a hip replacement? What would my patient want to achieve from a hip replacement? Well, it seems sensible that they would want to have a relatively safe operation, good positioning of the implants, which means it's going to last well long term, no muscle damage so that they don't have so much pain after surgery, because damaged muscles hurt. Yeah. So less pain after surgery, therefore quicker mobilization after surgery, and potentially, because these muscles aren't damaged, potentially less risk of dislocation, although that's contentious. But logic would say that if those muscles are back in position and working normally, the risk of the ball popping out of the socket may well be reduced as well. And some people are pleased that the scar is shorter. Personally, I'm not worried about the length of the scar, but my patients would be pleased with a good cosmetic appearance where it's feasible. So this technique, we can use a scar in the groin, which is even what we call a bikini incision. So it's in the lines of the skin crease, so you can almost not, you can't see the scar after maybe a few months. It really is a very cosmetic option.
How long would you say it takes? So, you mentioned that the patients that you saw, then they're up and they're walking along the corridor that day, the end of that day, having had the surgery. How long would that normally take for the patient is having the standard posterior approach to get to that point?
To get to that stage, I would say on average, it would be about 2 or 3 days.
Yeah.
So I mean, if I look at our length of stay data for the Royal Free Hospital NHS Trust, multiple surgeons, I'm the only one that does anterior approach surgery, but for the whole department, I think the average length of stay after routine hip replacement surgery is something like 3.5 to 4 days. Right. And don't get me wrong, some of my patients will stay longer even with anterior approach surgery, but my feeling is that the majority of patients are actually, from an orthopaedic point of view, fit for discharge the day after surgery. Right. And there are numerous units around the world who are offering same-day hip replacement surgery, in and out in the same day. And a lot of those units are using anterior approach as part of that system.
And just to sort of clarify what we mean by in terms of the muscle cutting that you described. So again, correct me if I'm wrong here, but imagine my fingers are the fibers of that sort of gluteal muscle at the back. With the traditional approach, we're kind of cutting across, so we're kind of splitting the muscle like that. Is that correct?
So the gluteal muscles, if you imagine these are all the fibers of the muscles, then you actually split the muscle open like this.
Okay.
So they're in the line of the fibers, but there is still a big rent in that massive buttock muscle, the gluteus maximus muscle, to allow you to get to the level of the side of the fiber and what we call the greater trochanter. And at that point, deciding either to go over the front of that bone or behind that bone to get into the hip joint. In one route, you have to damage and cut open and detach the gluteus medius muscle, and the other way, underneath the bone, you have to detach a couple of tendons, the piriformis and the obturator tendons, from the underside of the thigh bone. And all those structures need to be stitched back into place. And what people don't talk about is, especially with the root over the top, what we call the anterolateral approach or the hard hinge approach, damaging the gluteus medius muscle and then trying to stitch it back together. There is a percentage of failures of that muscle repair. And when that muscle doesn't repair well, then patients will permanently limp after surgery. You don't see that problem with anterior approach surgery because, as I said, the muscles are just swept away. You know, there's no damage to the muscle fibers. You go between muscle groups. It's what we call an internervous intermuscular plane, the root into the hip joint, without damaging muscles, without denervating muscles. And therefore, at the end of the surgery, those muscles just flop back into place.
That's excellent. Amazing. And you say, the glute medius is a very important muscle for the hip, isn't it? So it's
well, I've seen over my 15 years as a consultant, you know, a few patients who have been left significantly worse off by hip replacement surgery because their anterolateral hard hinge approach has resulted in failure of the muscle repair, and they're left with a permanent limp. And that awful lurching, what we call a Trendelenburg gait, after what looks otherwise to be a successful hip replacement, that's a significant major downside for the patient.
Are there any downsides at all, would you say, from the anterior approach? Is there any other risks, vascular risks to the arteries and whatever, the femoral artery and those sorts of things? Is that a factor? How much of a factor is it?
So any operation to the hip joint, there are different risks that you need to consider. Anterior approach surgery, I feel, is has a good safety profile in terms of risks, but there are potential risks. Any approach runs the risk of damaging to nerves. The bad news is if you have a standard hip replacement, a posterior approach, or indeed actually a hard hinge approach, there is a risk to damaging the sciatic nerve, the major nerve at the back of the hip joint, which supplies muscle throughout the leg. The anterior approach that I use, there's one nerve at particular risk, which is the lateral cutaneous nerve of the thigh, which is a sensory nerve only. It supplies the skin on the outside surface of the thigh, and there is a percentage of people that will complain of numbness on the outside of the thigh. If I was going to have a nerve injury as a result of a hip replacement, and I had a choice between a sciatic nerve palsy or an injury to the lateral cutaneous nerve of the thigh, I think I know which one I'd prefer. I wouldn't want to have either of them, but I think that's a difference in profile. There is some published data that indicates an increased risk of infection with the anterior approach compared to traditional surgeries. Some publications have documented a potential increased risk of excess blood loss as a result of the anterior approach. I think a lot of those issues relate to what we call the learning curve. So the ability for a surgeon to train to the point where he's perfectly safe to do the technique. As I said at the beginning, the technique technically is, I think, a little bit more challenging than a standard hip replacement. And so realistically, it's not something that you'd want to learn if you only do a few hip replacements a year. For the high volume surgeon, I think it's a perfectly appropriate and sensible way to do hip replacement surgery. Is there, for the majority of people, a big difference 6 months after surgery between a well-performed anterior approach hip replacement and a well-performed posterior hip replacement? No, I don't think there is a difference, apart from the cosmetic appearance of the scar, maybe. But in the early days, patient satisfaction scores are very high generally. As I said, if the surgeon is well trained and is using this technique routinely, I think the outcomes are very good. The risk profile is conducive, and for me also it's a benefit because the surgery is done with the patient lying on their back. Traditional hip replacement surgery, your patient's lying on their side. With the patient lying on the back, the anaesthetist is happier. They can manage the airway much more safely with the patient lying on their back. For me, it means I use X-rays during the operation. So I have an image intensifier in theatre during the surgery. So I can actually visualize with the X-ray rather than doing a hip replacement, even a navigated hip replacement, even a robotic hip replacement, the surgeon will finish the operation and want to have a check X-ray maybe the next morning to say, yes, I put it in exactly where I wanted it to go. I get that reassurance during the operation.
And that's
so I see.
Approach, then?
Sorry?
That's something you can't do with a posterior approach, is that?
No, you can do it, but it's more challenging with a posterior approach because the patient's lying on their side and the X-ray has to be tilted up over the patient, so that the positioning and it's a little, it's a little bit more challenging to do. It's not impossible, but it means that most surgeons don't routinely use X-ray imaging during hip replacement surgery, traditional hip replacement surgery. They may well template their X-rays prior to surgery, so they know what the size of implant they expect to use. They will predict where their implant is going to be, but they're left in a position where at the end of the operation they stitch up, and then they are waiting for the next day for the X-ray to see what the outcome looks like. Whereas I have that reassurance during the operation.
Got it. When it comes to the actual prosthesis itself, again, are there any limitations to that in terms of what you can and can't put in, or again, are all options open?
No, I mean the implant, it looks fairly generic compared to most implants that we use for hip replacement surgery. The socket, is identical. It's a standard. I use an uncemented socket, so it's a two-part socket made out of a metal outer shell, which has what we call a hydroxyapatite coating. This is a crystalline coating that the bone has a great affinity for. The socket is implanted into the pelvis as a jam fit, so it's a secure fit from the start, from the end of the operation. But then over time, a few weeks, the bone grows onto the surface of the socket and secures it into place. Inside that fits a liner piece, which is the actual bearing surface. There are options. You can use ceramic, you can use, again, polyethylene. On the thigh bone side, this technique is easier if we use an implant which has more of a sort of a curved banana shape to the stem. Some implants that are routinely used are a much straighter implant. They work perfectly well. It's just technically more difficult to put that sort of an implant in using the anterior approach compared to an implant which has a sort of curved shape to it, and it curves as it goes into the bone. It fits the bone that way much more easily for this technique. But the technology is fairly straightforward. We can use, on the femoral side, cemented or uncemented implants, depending on the patient's age and bone quality. And the uncemented implant, again, fully coated with hydroxyapatite to encourage bone growth onto it. The cemented version, a polished metallic component, which has the typical taper slip principles for a standard cemented implant, and it works very well.
And do you always use a stem prosthesis on the femur, or do you ever do like a resurfacing style of operation?
So resurfacing was something that you can do resurfacing through anterior approach. There's no reason why it's not feasible to do it. I think generally resurfacing has fallen out of favour. There's been an awful lot of press, even in the general press, not just in the orthopaedic press, but worries about metal on metal hips. The hip resurfacing is a great option if you're young, male, and high elite sportsman. Obviously, Andy Murray famously has had a hip resurfacing so that he can continue with his tennis career. But there are downsides, and in fact, I believe that there's a documentary about Andy Murray's hip resurfacing that you can watch on the TV, and his surgeon, very well-known surgeon, made it very clear to him that she was happy to do a hip resurfacing for him so that he could carry on his tennis career, as long as he understood that there was a significant chance that within 7 or so years that hip may well fail and he would have to have it redone. And I think for most of the general population, you don't want to have a hip replacement of any sort thinking that within 7 years it will have to be further, there'll have to be further surgery.
Yeah, no, it's not that long, is it? Excellent. And then
most of my patients want me to tell them that they'll have a standard style hip replacement which has a greater than 95% survival at 10 years, greater than 90% survival at 15 years. And we know that, again, data from our national joint registry, a hip replacement with a polyethylene socket and a ceramic ball in it has the best longevity data according to our national joint registry. So for me, that's
ceramic on the end of the femur and the articulated polyethylene in the SSA.
Exactly.
Yeah, and as you say, the ceramic quite a lot less wearisome than a metal.
Exactly. For some very young patients, might consider using both a ceramic socket and a ceramic ball. Potential that there may be better longevity with that. There are downsides with using ceramic against ceramic as well. So for most patients, I don't think that's necessarily the best option. But we know what the bearing surfaces are doing with hip replacement surgery. That's one of the joys of having this fantastic joint registry that's been running for decades, and the outcome data clearly shows us what works and what doesn't work.
Yeah, just briefly then, what you mentioned just there, the downsides of ceramic on ceramic. What might they?
The big one is squeaking.
Okay.
If you have a ceramic socket and a ceramic ball, a percentage of patients will say that once they've fully healed, they are aware of a feeling of squeaking in the hip, or even other people will hear that their hip squeaks as they walk. And although it may not make a difference to the longevity of the implant, it's not a particularly pleasant thing to have a squeaky hip joint. And in those situations where we've actually retrieved squeaking ceramic on ceramic hip joints, you actually see where the ball and the socket have been rubbing atypically, and you get stripes of wear on the socket, which are clearly indicating that biomechanically it's not working the way it should do. It's not a barrier to having a ceramic on ceramic hip replacement, but it's something to be borne in mind when you're deciding for your particular patient what's the right alternative.
Okay. And the last question, I'm anticipating a similar answer to this question I want to ask you about the knees, but again, for somebody who's having a hip replacement, as you described, anterior approach, on polyethylene, again, how active is their general thumb? How active can they be?
So the good news is with hip replacements, unlike, as I was saying, with knee replacements, where a lot of people will be delighted with their knee replacement but know that it's not their own knee replacement. With hip replacements, we have a very high success rate in ending up with a patient who literally does not notice that they have an artificial hip joint. We talk about the concept of a forgotten or a silent implant. So the patient does not think about the fact that their hip is artificial at all. And that's quite common with hips, unusual with knees, but quite common with all hip replacements, whether it's anterior approach or posterior approach. The success rate for hip replacement surgery in terms of patient satisfaction scores is very high. So again, it comes back down to patient's expectation. I would not put a barrier for my patients having a very sporty, active lifestyle. With a traditional hip replacement technique like a posterior approach or a hard hinge approach, I am worried about the quality of the tendon and muscle repair and the potential risk for dislocation. It doesn't seem to worry me. If you have an anterior approach hip replacement, a lot of patients get advised that after surgery for 6 weeks they have to sleep on their back. They can't sleep on, whichever is their hip replacement side. None of that with anterior approach. Your patient can lie wherever they want to. There's no real restrictions. I don't mind whether they want to, they don't need to have to use a seat raiser on the toilet. They don't need to be worried so much about, a low chair, which are traditionally worrisome for patients with standard hip replacement surgery. So a lot of these early restrictions just don't seem to be relevant for anterior approach surgery. But moving forwards from that, once patients are recovered, and a lot of people are fully recovered within 6 weeks to 2 months after surgery, they will stroll into the clinic with no limp, with no pain, with a smile on their face and say, "Thank you very much, job done." And at that stage, I will say to my patients, with pleasure, go away and use your hip replacement as you wish to. I'll again engage in conversation with them about the pros and cons of a more aggressive or active lifestyle, but it's up to them. It's up to them to decide what they do.
If and when it does, or if, let's say, worst case scenario, in X number of years' time, they would have to have that replaced because whatever, they've been overly active. Is that an easy operation, not easy operation in the hip, or?
In general, hip revision surgery in general, or specifically after anterior approach hip replacement?
Yeah, either or both. Yeah. Both.
I don't think that anterior approach replacement makes any difference to the technical difficulties of revision surgery. Whether you reuse the anterior approach, you can do revision surgery through the anterior approach if it's been done by anterior approach for the primary hip replacement, or you can choose to use a posterior approach if your preference is a posterior approach. It makes no difference to the complexity of surgery. Hip revision surgery has come along in huge leaps and bounds in the last 20 years. The techniques for reconstructing bone defects, again, it's bone loss that can often be the issue. Reconstructing even massive bone defects has become easier and easier with the introduction of more interesting technology, especially on the socket side, where you get bone loss inside the pelvis, where traditionally a lot of surgeons would battle for a long time to bone graft defects, fitting wire cages around the defective area and then packing fragments of bone graft into the area, then waiting for several months for that bone graft to incorporate. Nowadays, we often use metallic augments to help with the reconstruction. A great metal that's been discovered to work very well in orthopedic surgery called trabecular metal. It's a tantalum. It's an element called tantalum, which you can make into a honeycomb structure of any shape and size that you wish. It has many of the characteristics of normal cancellous bone, and you can use that to rebuild often very large defects within the bone. So yeah, very, very, very different for the surgeon nowadays compared to maybe 20 years ago. Most patients won't have such a complex problem that it isn't feasible to rebuild their failed hip replacement.
Yeah, oh, fascinating. That's amazing. Wow, that's yeah, but I learn even more stuff every time I talk to you guys. I learn a little chunk of it, something extra. So it's really good. I'm just going to come back to one final question, which I just want to go back to knees again.
Yes.
Patellafemoral joint. So that's kind of in many ways, a different. Obviously, it's the knee, but it's like a different compartment of the knee. And again, I know from my previous discussions with other surgeons that again there tend to be different thoughts in terms of always replace it, don't replace it unless you really have to. Where do you sit with that kind of that argument or that question? Would you always try to...
Again, the joint, if you're talking about for standard primary knee replacement surgery, the joint the joint registry data is useful for us, and there are a number of published reports on outcome data for different designs of knee replacements with or without replacing the underside of the patella of the kneecap. It's important to know your implant. If you have a knee replacement implant which is, in inverted commas, patella friendly, then there doesn't seem to be much in terms of benefit available to replacing the underside of the kneecap. If you have an implant which doesn't have a particularly patella friendly groove, the trochlear groove, the groove that the kneecap sits in, then if you don't replace that patient's kneecap, then anterior knee pain after knee replacement surgery is going to be more of an issue. And there are different stories, different rules for different designs. Most of the more modern designs are actually quite patella friendly. There are occasions when you feel that you do have to resurface the patella. If the kneecap doesn't sit well onto the front of your knee replacement design, once you've finished the majority of the operation, if for some reason that kneecap doesn't sit nicely within the groove that is there on the surface of the metal implant, then occasionally you have to start addressing that so that the patient will be satisfied with their knee replacement. Whether that means releasing soft tissues to improve the position of the kneecap in the groove, or sometimes actually to decide to resurface the kneecap, specifically to thin the kneecap out. If you have a very bulky kneecap and the size of the kneecap means that it wants to tilt off the surface of the thigh bone implant, no amount of release will necessarily improve that. But once you've resurfaced the kneecap and chosen to resect more of the kneecap than maybe you would normally do when you do a resurfacing, you can actually improve the position of the kneecap on the surface of the thigh bone. So that's a rare situation, to be honest. If a patient specifically complains of significant anterior knee pain, as a major component of their arthritis within the knee. And when you open up the knee joint, there really is very bad ridging and grooving, bare, what we call eburnated bone on the surface of the kneecap. Then some people will look at that and say, well, this patient is not going to be satisfied without a resurfacing of the kneecap. So that's a judgment call that the surgeon may well take at the time of the surgery. But there are some surgeons who will look at the published literature and say very clearly, knee replacements work very well when you always resurface the patella. And there are some surgeons who will pull up another series of papers which say knee replacements always work very well as long as you don't resurface the patella. So there is not a black and white answer. Famously, there was a well-known orthopaedic surgeon who used to go to the UK National Conference for orthopedic surgeons every year, and they would often have a debate pretty much every other year about whether or not, this is back in decades ago, and there would be a debate: should you resurface the patella at knee replacement surgery? Should you not? And famously, on one occasion, he stood up and he said, "I've done a lot of knee replacements over my career, and one thing I can tell you is very clear: you should always resurface the patella." And then he turned up at the meeting a few years later when they had the same debate, and he stood up and he said, having studied this very, very extensively, I can tell you, you should never resurface the patella. So if one surgeon with a great experience in knee replacement surgery can't make up his mind, then maybe there's not a right or wrong answer. Personally, my own practice, I've seen the number of patients having resurfacing under my practice drop significantly over the last decade. But that's partly to do with the fact that we've changed the routine knee replacement implant that I use in the NHS from an implant which maybe isn't as patella friendly, and therefore I felt that I had to do resurfacing of the kneecap quite frequently. We now use an implant which is much more modern, much more in design, it's more patella friendly. I don't feel the need to resurface the patella.
I'm guessing what you were referring to there isn't the conformist then on the NHS, is that right?
No, the conformist is an implant which, I mean, it's not a huge amount more expensive than a standard knee replacement off the shelf in the NHS. The CT scan that you have to spend money on before the surgery, plus the added expense of the manufacturing of the cutting jigs, means that within the NHS, it's just not economically viable, I don't think. When you start looking at volume, if you're talking about the occasional patient who maybe should have this sort of implant, there's if you can come up with a good reason to justify an added expense for the occasional patient, but if you say, well, we're going to do conformist for every patient in the NHS, the bill would be, unrealistic.
Unrealistic to the outcome. Are you able to give us the name of the one that you do as standard on routine on the NHS?
At NHS, I use something called the Next Gen, which is an implant made by Zimmer. It's one of the biggest, sellers worldwide in knee replacement surgery. It has excellent outcome data on the National Joint Registry for a standard off-the-shelf knee replacement. It offers me a lot of options for variability to help me with that task of trying to match sizing to the particular patient. Unlike other designs of knee replacements, the Next Gen implant that we have off the shelf comes in not only different sizes but also different widths. You can select a narrower width implant or a wider width implant for a particular patient. It also has different options to help with range of movement. It has something called a high flex alternative version, which for some patients may well improve range of movement after surgery. So the inventory, the number of implants that I have on the shelf in theatre is a bit bigger with Next Gen compared to competitor designs, but I can find that quite useful for managing my patients, intraoperatively, where I'm in a situation where I'm trying to get the best fit to improve outcomes, hopefully.
Amazing. So is that literally the case? You have more lined up on the shelf, and it's like, I'll go that one, that one, that one, that one.
It's not actually in theatre. They have shelving in the storage area, and so when you do a knee replacement, once you've opened up the knee and done the resection of the bone margins, you've measured what size implants, then there's a runner who you instruct what particular sizes of implants you're going to require, and they get brought in, sterile, packed in a box. there's a lot of care taken to make sure that we implant the correct implant for the correct patient. So there are timeouts during the surgery where we stop and all focus on making sure that what we're going to implant into the patient is what we need to get the best outcome for the patient.
Yeah, got it. A bit like, yeah, I suppose it sounds a bit like going down to your local shoe store and say, bring me up a size 7, please. You know.
Yeah, 7G, I think. 7G.
7G, yeah, exactly. No, a bit more technical than that, but no, that's excellent, fascinating. Well, Simon, thank you very much. That's been really, really enlightening.
It's a pleasure, been a joy.
I knew it would have been. I'm sorry I've gone over time because I was expecting to keep the half an hour, but
no, absolutely.
The questions kept flowing, and so your knowledge is just immense and the experience is immense. So thank you. I think anybody who's seen this video will find that really fascinating. So,
it's my pleasure.
Thank you so much. Really, really, really interesting. So, yeah, thank you.
Excellent. Well, no, it's my pleasure. Always enjoyable. I find these sort of this sort of method, this sort of form, it suits me very well. Hopefully, I don't rabbit on.
No, nothing.
Further than is necessary. I try. Hopefully, also for your viewers, I try and at the back of my mind think that I'm not using too much technical jargon. You know, I know I'm talking to allied health professionals who have a degree of knowledge, so maybe I'm underselling it. But I want to be able to appeal. My delivery. I need it to appeal to the whole group, whether or not they are experts or not.
Yeah, this will hopefully going out to, as you say, people in the profession, in the healthcare profession, but also just to patients as well. And I think
good.
Across really well in the description. So yeah, thank you. Thanks again.
No, my pleasure.